Welcome everyone to this really important and timely webinar. We have today hundreds of people joining us for this webinar, including of course the CNO BME group, which I've been asked to give a shout out to. So thank you, Felicia, for bringing over 200 nurses to this webinar today, to a timely webinar. Timely because today also marks the first death anniversary of George Floyd. As we know, his death led to worldwide calls to tackle racial discrimination. The fact is that we cannot claim to live in a forward-thinking, progressive society if members of that society are treated deficiently because of the colour of their skin or because of where they come from. What we know is that racial discrimination is a global and system-wide issue requiring a global and system-wide response. And our healthcare system, whilst not the only enabler for equity, but certainly an important one, has recognised the need to focus on these issues. The establishment, therefore, of the NHS Race and Health Observatory enables us to do exactly that. The observatory's function is threefold: to catalyse and facilitate insight and evidence on ethnic, racial, health inequalities, to turn that insight into evidence-based recommendations for change, and thirdly, to support and facilitate the practical implementation of those recommendations on the ground. And that is exactly what we have begun to do. Our work programme within the observatory enables us to focus on some of the most deep-seated, deep-rooted inequalities, to proactively respond to critical areas in this agenda as they emerge, and to ensure that our responses to ethnic health inequalities are informed by community participation embedded within cutting-edge, innovative and global thinking. So today we will hear from renowned experts and leaders as they discuss the health recommendations of the recently published CRED report. They will do so with an open mind and an honest heart, because we all have a role to play in tackling the stark inequalities that we see within society. And to do that, we need to ensure that inequalities are addressed not just by the words, but by deeds and by actions. That is exactly what the observatory has been designed to do. And on that note, I'm delighted to announce that today we have launched the NHS Race and Health Observatory's website, www.nhsrho.org, and we will place that address in the chat box. Please also use the chat box for submitting your questions to the panelists, as we will be having a Q&A session a little later on. Finally, I'd like to thank the fantastic team behind the organisation of this webinar, and of course, our esteemed speakers, James, Michael, David, Chaand, Vahe, Patricia, and Jacqui. So I guess it's time now to hand over to the chair for today's webinar, the excellent Professor James Nasru, Professor of Sociology at the University of Manchester, Observatory Board member and co-chair of its academic reference group. Over to you, James.
Thank you so much, Habib, for that nice introduction, and also the introduction to the event. It's a real privilege, honour to be here, not least because of the audience and the fantastic audience who are here, and the discussion we'll have, but also because of the outstanding set of contributors who we will hear from shortly. These are people who are world leaders in the field, in their fields of work, and so we are extremely privileged to hear from them. I've been doing work on ethnic inequalities in health for over 25 years, a track record that sounds long, but not compared to some of the people who are present here. And I've really focused on questions of social and economic inequality underpinned by racism and how they drive ethnic inequalities in health. And so this event is a crucially important landmark in terms of our thinking in relation to this, not least because it's focusing on the report from the Commission on Race and Ethnic Disparities. So it's that we will focus on. The Commission, as you will probably know, was established by the UK government last summer, and it published its report in March this year. So the report is still relatively new. And at the time, the report has led to wide-ranging discussions and some critical commentary, of course, and a number of events that critically engaged with the report. But the bits of the report that focus on health have not been the subject of much debate. And so that's the purpose of this event. We get the chance now to focus on what this report said about health disparities and the recommendations that they make in that regard. Having said those couple of minutes of introduction, I'll just say a little bit more about the context of the report, because I think it is worth thinking back to the context of the report. And of course, Habib has talked about that a little bit. One crucial bit of context, of course, was the resurgence of the Black Lives Matter movement that followed the murder of George Floyd. This was a resurgence that happened not just, of course, in North America, but happened across the global north. Almost all countries in the global north witnessed a number of protests and demands for equality and so on. But those protests were often met with vigorous policing and sometimes with violent far-right counter-protests. And this happened, of course, in the UK as well as elsewhere. So that's one crucial piece of context. The other crucial piece of context, of course, is the emerging evidence of the extremely marked ethnic inequalities in COVID-19 related mortality, and in the social and economic harms that resulted from lockdown and associated policies. And just to put this in context, when I began my career looking at ethnic inequalities in health, ethnic inequalities in relation to cardiovascular disease were a crucial issue. And there we were looking at something like a 30 to 70% increased risk of mortality for some ethnic minority groups. Here, in relation to COVID-19 related mortality, we're talking about 2, 3, and in some cases 4-fold higher rates of mortality. That gives you a sense of the order of magnitude of the inequality that COVID-19 has revealed. Two pieces of context. The third piece of context, and one that perhaps is not so obvious to all of the audience, is that Theresa May, when she became Prime Minister, acknowledged ethnic inequality and established the Cabinet Office Race Disparities Unit. This was established to collect data from across government departments and to hold those departments to account in relation to the inequalities that they were measuring in terms of the outcomes of their work. What's important about the Race Disparities Unit is that those data became then a crucial resource for the Commission. And that's why the Commission was able to mobilise evidence so rapidly. And it's important to recognise and acknowledge that. And I want to briefly raise two other bits of context that perhaps are less immediately obvious, though when I mention them, they will of course become so. The first is Brexit, and what Brexit was accompanied by, and it was accompanied by a rise of anti-immigrant hostility, which then spread out to a broader impact on race, ethnic relations and identities within the United Kingdom. And it's important to bear that bit of context in mind. It shows how the political and social and attitudinal context shifted over the years leading up to 2020. And the other bit of context is the ongoing Windrush scandal. The Windrush scandal, the forced removal of British citizens where their citizenship was questioned, the evidence behind their citizenship had been thrown away, had been destroyed. This scandal is ongoing. The compensation that these citizens are due has not yet been paid. The mechanisms through which they're being treated continue to be harsh. And in this context, I just want to give you a sense of how this did not feature in the CRED report. So the Windrush scandal is mentioned in the CRED report, but the CRED report, and I quote now, says, "Outcomes such as these do not come about by design and are certainly not deliberately targeted. But when they do occur, every step needs to be taken to ensure that the reasons why they happened are understood fully and the causes then acted on to ensure that they are not repeated. The reason why I read that quote out in full is because it starts off by saying that they're not by design, but then does the good thing and says that we need to solve the problem. I don't think we can solve the problem unless we understand how they come about by design. And I'll very briefly say something in relation to that in a minute. But I've almost finished what I'm saying by way of introduction. And the next thing I want to say in terms of introduction is to say that although the report was rapidly produced, it did mobilise a substantial body of evidence. That evidence, as I mentioned, produced by the Race Disparities Unit, but also by other groups who submitted evidence. One big advantage of this is it means that the body of evidence on inequality is now visible. So if you look at the report, look at the references within it, trace those references back, and look beyond the ways in which they're used, the almost cherry-picked use of this evidence, you can see the broader evidence on inequalities in relation to ethnicity in the UK. Another thing to say about the report, and of course this is the elephant that will soon become very visible in the room, is that its broader approach is really now infamous for the ways in which it downplayed the significance of racism. Academics like me would argue that it failed to thoroughly conceptualize and grasp how structural racism, institutional racism, and interpersonal racism impact on and shape our lives. Its failure to do that, I think, is crucial in terms of looking towards the origins of inequality and addressing fundamental causes in terms of inequality. As I said, the focus of this event is on the recommendations in relation to health disparities. And here it's worth highlighting that the Commission has strongly suggested that we need to move away from a focus on ethnicity and away from a focus on racism. And a part of its rationale for doing that is that it argued that for outcomes such as life expectancy and mortality, ethnic minority groups fare better than the majority. And it then goes on to argue that we need to move towards a focus on deprivation, on geographical inequalities, and on differential exposure to risk factors, whatever that might mean. And to support this, it recommends, amongst other things, it recommends that the government establishes an independent office for health disparities. This office would focus on research, on mobilising evidence to target deprived communities, to develop tailored health interventions, education and communications. Now, my initial response to this, of course, is at one hand, we of course do need to address broader social inequalities in health, but we also need to maintain a focus on ethnic inequalities. And this is what this discussion is about. But also, that if we're going to do that, then we need to conceptualize and understand health inequalities appropriately. So we need to move beyond a surface description of whatever these tailored health interventions might be, health education and communications. These aren't the solutions to the health disparities that we face. So I'll end my introduction now and go on to introduce speakers. As I said, we've got an absolutely fantastic, world-leading group of speakers here doing the most cutting-edge work in their fields. I'll introduce them one by one, so I'll introduce them just before they speak, and just a brief introduction for each of them, and then ask them to go ahead with their talks. Afterwards, we will then have a question and answer session where the speakers will remain and will be able to respond to your questions, and then we will close. So save your questions to the end, do keep a record, post them on the chat, and they will be collated and presented to our speakers at the end of the session. So I'm really pleased to welcome our first speaker, and I apologise if I pronounce your name slightly wrongly. This is Vahe Nafilyan, who is a principal statistical methodologist at the Office for National Statistics. It is absolutely great to have Vahe here because he has been he has led much of the analysis that has been conducted by ONS to examine and explain ethnic and religious differences in the risk of COVID-19 related mortality. Of course, his work is much wider than that, but this has been an absolutely crucial intervention over the last year and a bit in terms of our understanding of COVID-19 related mortality. So, Vahe, over to you.
Thank you very much, James, for this very kind introduction. Can I just check that you can see my screen?
Yes, we can.
Perfect. So as James said, I'm a statistician at ONS, working in the health analysis and life event division. And I'm delighted to be here today to present some of the work that we have done at ONS on the unequal impact of the COVID-19 pandemic on ethnic minority groups. So I'm going to present briefly the work we've done on COVID-19 mortality and also on the vaccination coverage that we've done more recently. So, as you are aware, monitoring health inequality inequalities in health outcome is very important, but it's made especially during a pandemic when timely evidence is needed to guide policy response. However, it is difficult to do so, especially sometimes on ethnicity, because of the limitation of the existing data. So why is it difficult for ethnicities? Because when you want to look at outcomes that are relatively rare, such as COVID mortality, on groups that are relatively small, you need very large data sets to be able to do that. And all the existing data sources have issues. So one crucial type of data used for monitoring inequalities is surveys, where people ask questions and about their health and about other dimensions of their life, and then are analyzed. So surveys are great because they are very detailed, but they also have drawbacks because they're expensive to conduct, and therefore sample size tend to be relatively small, and which limits the ability of researchers to investigate ethnic inequalities in health. On the other hand, there are electronic health records, so that would be records from primary and hospital data, which are great because they are population-wide coverage, but they also suffer from some shortcomings, such as the lack of information about social demographic factors, and also sometimes a questionable, in some cases, recording of ethnicity. So I'm not going to bore you about all the details, but what we've done at ONS is trying to create a new data source that combine the advantages of the two types of data sources by linking the 2011 census to electronic health records, because the census collects a wealth of information about people, including their self-reported ethnicity, and also a wide range of social demographic factors, which is crucial to look when we look at health inequalities to understand the intersectionalities between the different factors. So what we've created is called the ground name of the public health data asset, which is going to be an evolving data set, but at the moment it's a data set very much focused on the pandemic. So it's a data set that about 40 million people aged 9 or over that were alive at the beginning of the pandemic. And we have a wealth of information about these people on demographic factors, socioeconomic factors, occupation, geography, and also a very detailed clinical history. And we cover a good about 80% of the population, and even more so when we look at older adults. So it's a very good data set. It's got some limitations, such as it does by default, because it is based on the 2011 census. It would exclude all recent migrants, so that's a limitation. And some of the characteristics will be outdated as well. So it's not the silver bullet, but it's a significant improvement to the existing data sets. So for those of you who are researchers, so this data set can now be accessed on the Secure Research Service at ONS for external researchers to use. And I'm going to present you a few analyses we've done with this data set. So the first one was an analysis we did of how COVID-19 mortality varies between ethnic groups, focusing on here people living in England in private households who were aged between 30 and 100. And we look at COVID-19 related deaths, so both either in hospital or out of hospital. And the way we measure COVID related deaths is by looking at the death certificate rather than just a positive test. And what we've done is trying to present a measure of inequality, so accounting for age, looking at how different COVID-19 mortality rates look like, and also if you are trying to explore why, if the differences are driven by some structural factors. And okay, sorry. So here is the relative risk of COVID-19 mortality compared to the white British group for men and women separately for the first wave of the pandemic, so defined as deaths occurring up to the end of August, and is from different models, so adjusting for different things. So in purple here, it shows the relative risk compared to white British when we just account for age. So this is the true measure of inequality in a sense, because that doesn't account for factors that would could be also related to ethnicity. So that's a true measure of inequality. And here, as James said in introduction, you can see extremely large race risk for most ethnic minority groups. So especially Black African in the first group were 4.5 times more likely to have died of COVID-19 than white British people of the same age, but also raise risk for people from Bangladeshi and Pakistani background, Black Caribbean, and all group, and with a consistent pattern between men and women. So then what we try to do with our data set is try to understand, so why are there such strong differences? And these differences can be due to either an increased risk of infection or, if infected, an increased severity. So what we try to do is to adjust our models for factors that are first linked to factors related to infection, so geographical factors, and then social demographic factors, and finally for health related outcomes. And what we find is that adjusting for geography, so where people live, matters a lot in terms of explaining the race risk in the first wave. And so does the social demographic factor for some groups. In comparison, pre-pandemic health had the lower explanatory power. So it suggests that the differences are driven by factors that are more likely to be, that are related to infection rather than to severity. So now in the second wave, so that's the data, how the inequality looked like during the second wave, the first half, the beginning of the second wave, I should say. So this is a limitation that we only look at data until the end of December. Tomorrow on the ONS website, we are going to publish an update of this, looking at deaths occurring up to the end of March. So the picture would look slightly different, especially for Black African and Caribbean. So in the first half, with the first part of the second wave, you could see that Black African and people from Black African and Black Caribbean background were no longer at greater risk of COVID-19 mortality compared to white British. And this has changed slightly when we look at more recent deaths. So I can't comment on it in detail, but it has increased a bit again. But what is extremely striking here is that the risk among people from Bangladeshi and Pakistani background has increased dramatically compared to white British in the second wave, being really raised risk. The risk for Indian has decreased comparatively, and also had for Black African and Black Caribbean. What we can also see is interesting is that the explanatory factors have also changed. So the geography used to explain a lot for Bangladeshi men and women, but in the first wave, but not as much in the second wave. So it suggests that the pattern of infection is different here. So the implication of this work is that we find extremely large inequalities in COVID-19 mortality. It's much larger than inequalities we usually observe when looking at other other diseases. And the changes in differences between wave 1 and wave 2 show that it's likely due to difference in infection. And in a way, it is good because it means that policy and intervention can help reduce inequality. And to an extent, the inequalities have been reduced for people from Black Caribbean and Black African background. So now turning to another very important outcome, especially going forward, is the inequality in vaccination coverage by ethnic groups. So what we have done is adding the vaccination data provided by NHS Digital to our data set, and that allowed us to look at vaccination rates broken down by ethnic groups. And what we find is, so here what we show is the first dose vaccination rates of adults aged 50 or over by the 12th of April. And we do find large differences between ethnic groups, with the highest rate vaccination rate being for white British, and lowest for Black African at 66.8%, and Black Caribbean and Black African, and then followed by Pakistani. So here so the ONS report you can have a look at. It breaks down by different social demographic groups, and we find that the differences by ethnicity and religion are the largest ones. So there are, even if you look at dimension of social demographic, social economic factors and other factors, the differences aren't that large. So there is really something going on here. And what we've done as well is, if we're comparing, so looking at the probability of not having received the first dose, that's what we look at here. And we try to see, is this due to other factors, or such as place of residence, education, household tenure, and so on and so forth. And we compare the unadjusted with the fully adjusted. So we see a reduction when we adjust for other factors, but they remain extremely high. So over 5 times more likely not to be vaccinated among Black Caribbean compared to white British, and raised for all the ethnic groups, and more than twice. So here, suggesting that there is really something indeed related to ethnicity, to ethnic affiliation, and not to other factors. So what the implication of our work has been that ethnic minority group not only had a greater risk of COVID-19 deaths, but also a lower probability of being vaccinated. And that's a recipe for disaster if further waves come. So increasing the vaccination rates among these groups is absolutely crucial, and a lot of good work has been done. And we are continuing to monitoring the uptake to see if all the community-led interventions and public figures calling for people to get vaccinated have worked. So thank you very much for listening, and we'll make the slides public and you can access all the reports, and keep an eye out for the ONS release tomorrow on COVID-19 vaccination in the second wave. Thank you very much.
Thank you very much, Vahe. That was a great talk, and it highlights both the, I'll say it again because I'm not sure I was live. Thank you very much, Vahe. That was a great talk, and it highlights both the inequality in outcome, but also the inequality in access to services, but also the important role that the Race and Health Observatory plays in both looking at this evidence and promoting intervention. And some of you will know that the Race and Health Observatory has done quite a lot of work around vaccine uptake. Okay, I now turn to our next speaker, who is David Williams, who is a professor of public health and chair of the Department of Social and Behavioral Sciences at the Harvard University T.H. Chaand School of Public Health. He is the world's foremost authority on race and health inequality. So we are very honoured to have him here. His work examines the various and complex ways in which socioeconomic status, stress, racism, health behaviour and religious involvement impact on health. And is a very wide-ranging, very high-quality body of work, as you'd expect from someone who is almost certainly the world's leader in the field. So I'll just hand over to you, David, to kick off. Thank you so much.
Thank you so much, James, for your very kind words of introduction. And it's truly an honor and privilege for me to be here with you today. What I want to do, I actually will not present data on COVID-19, but I want to present an overview of what we know of a global pattern of racial inequities in health, and then talk about the role of socioeconomic status and the ways in which racism even shapes racial ethnic inequities in socioeconomic status. So I'm going to share my screen so that you can see my presentation. You can see it okay?
Yes, we can. Yeah, though it's not in slideshow mode.
Okay. All right. So the role of SES and racism in racial inequities in health. So I'm going to begin by making the point that the patterns we see of racial ethnic inequities is a global phenomenon. And I will illustrate that with infant mortality, the chance of an infant dying before its first birthday. And I showed data here from Latin America showing the higher death rate, infant mortality rate for persons, infants born to Afro descendant of Black descent in Latin America. And you can see across multiple countries, Costa Rica, Panama, Uruguay, Venezuela, Brazil, Ecuador, Colombia, you see elevated death rates for persons of African descent. In Latin America, again, you see elevated death rates for persons of indigenous descent, in original indigenous populations. Again, look all across these countries, you see a pronounced pattern. And so the question is, what drives these large racial inequities in health? And well, there are large inequities in health by socioeconomic status. I'll abbreviate it SES, income, education, occupational status in the US and elsewhere. And there are large racial ethnic differences in socioeconomic status. So here is national data for the United States showing that racial ethnic differences in household income, and I've standardized it on $1 of income for whites. This is for 2018. And for every $1 of income whites receive, Asian households receive $1.23. Asian household is a category used in the United States that refers to persons who come from 60% of the world's population. And it's a group heavily made up of immigrants. Almost 70% of Asians in the United States are immigrants, and they've come to the US with very high levels of education. And that in part is a contributor to the pattern you see. But more importantly, Asian households have more persons contributing to household income than other groups. But if we look at the historically disadvantaged groups, for every $1 of income white households receive, Hispanic, persons from Spanish-speaking, mainly Latin American and Caribbean countries, receive 73 cents. And American Indians, the indigenous population, and the Black population receives 59 cents. What is striking about the 59 cents figure for Blacks is that it's identical to the Black-white gap in income in 1978. So the persistence of inequities is quite striking in these data. Just to show you one other country example, here is income levels by race in South Africa, and again standardizing on R1 for the white population. And you can see for every rand of household income the white populations receive, Blacks receive 20 cents and colors 40 cents, and the Indian Asian population there 60 cents. The same is true if we look at data in Latin America, in Brazil, in Ecuador, in Peru, in Uruguay. You can see a higher proportion of the Black population, the Afro-descended population, living under conditions of being in the lowest quartile of income. And even these large racial gaps in income markedly understate the racial gap in economic status. Because income captures the flow of resources into the household. It doesn't tell us about the economic reserves that households have to cushion shortfalls of income. And here is data for the US on wealth, the assets, the economic assets, the home equity, the savings, the financial investments that households have. And you can see even more striking inequities in health. Now, at one point, researchers thought that the racial ethnic gaps in health was simply a function of racial ethnic differences in income and education. We now know life is much more complicated than that, and I'll illustrate that with infant mortality data. Here's infant mortality data for the United States, and you can see the Black and the indigenous, the American Indian population, having markedly higher rates. Here is infant mortality data for the United States by race and the income, as well as the education level of the households. And what you can see here, less than 12 is less than high school completion, some college, a college degree, and more education. And you can see that education matters for every group. Here's the white population. As education increases, risk declines, and it declines quite markedly. And that's true for every group. Here's the Black population. It declines quite markedly. At the same time, you see an excess risk even after we've taken education into account. So look at the best of Black women. Black women with a college degree or more education have rates of infant mortality that is more than twice as high that of women of other racial groups. And you see this pattern also for the Native American population, quite elevated risk. So clearly, there's something about income and education that matters, but there's something else that is producing these patterns. Here is infant mortality data by race for South Africa. And these are not the bivariate data, but these are after adjustment for demographic factors, for income and education and other risk factors, you still see these are odds ratios now, and you still see the colored, the Asian, and the white population having markedly lower levels of infant mortality in South Africa. So why does race still matter? Could racism be a critical missing piece of the puzzle? And I want to talk in the time I have today just about one mechanism of racism, the institutional or structural or systemic discrimination. That's discrimination embedded in laws and macro level policies that can have enduring effects. And in the context of the US, I will talk about residential segregation, which was a historic policy. It's been ruled illegal since the 1960s. But the structure put in place by the 1940s is still in place in the US today, where you could live was a function of your race. And this is how you can think of residential segregation. I think of it as a burglar at midnight that slips into a community, and when it shows up, valuable resources no longer exist, like quality schools and safe playgrounds and good jobs and healthy environment and safe housing and good transportation, and even in the US context, good access to medical care. Let's consider some empirical evidence. Two of America's most eminent sociologists, William Julius Wilson and Robert Sampson, studied the 171 largest cities in the US, said there's not even one city where whites live under equal conditions to those of blacks, and the worst urban context in which whites reside is considerably better than the average context of black communities. Another study by a professor from Brandeis University, Dolores Acevedo Garcia, she put together what she called a neighborhood opportunity index, ranking every geographic unit in the United States, every census tract, on 27 different indicators of access to opportunity, like the quality of schools and the graduation rate and the employment rate and the income level and exposure to environmental hazards and resources for good health. What she shows in the 100 largest metropolitan areas in the US, if you look at who lives in the very low and low opportunity neighborhoods, it's 2/3 of all black children, 58% of all Hispanic children, 53% of all indigenous children are living in the lowest opportunity neighborhoods compared to 1 in 5 white and Asian kids. The opposite is true in the high opportunity neighborhoods, where almost 2/3 of white and Asians live in the high opportunity neighborhoods compared to 1 in 5 of the disadvantaged racial groups. So neighborhood and access to opportunity at a neighborhood level is a powerful driver of inequity. In fact, research in the United States by economists show that this mechanism of structural racism, segregation, is the reason why we see these large racial ethnic differences in income and education. Here is a paper by David Cutler. He shows if you could statistically eliminate segregation in national data of the US, you'd completely erase black-white differences in income, education, unemployment, reduce black-white differences in single motherhoods by 2/3. All of these stark differences are driven by racism through an upstream mechanism. More recently, another Harvard economist, Raj Chetty, does an intergenerational analysis. He starts out with black and white households at the same level of income, and he says, how are their children doing in the next generation? He shows that in 99% of census tracts, the small geographic areas, black boys do worse in income than white boys, even when they started out at the same level of income. Why? They live in neighborhoods that differ in access to opportunity. So access to opportunity is a powerful driver, and then segregation, combined with lower economic status in disadvantaged neighborhoods, leads to higher levels of economic stress, psychosocial stress, physical and chemical stressors that also produces ill health on, in fact, a large scale. Plus, there's exposure to interpersonal discrimination, which I will not talk about in detail. What I'm saying today is that when we look at even the racial differences in socioeconomic status, we have to recognize there are inequities that exist by design. They do not reflect a broken system. They reflect a system that was carefully crafted and is functioning as planned, successfully implementing social policies, many of which are rooted in racism. They are not accidents or acts of God. They do not reflect primarily the behavior of individuals. Racism has produced a truly rigged system of inequities in the United States and elsewhere. I hope this gives you some context of the role and the interaction between racism and even the socioeconomic status indicators. Thank you so much.
Thank you, David, for such a powerful talk. And I think that message, inequities by design, and the way in which you illustrated how that operates in a particular context in a particular way is a lesson that we really need to take to heart and to think about UK social structures, economic structures and institutions with that critical eye. Inequities by design are very important and well illustrated point. Our next speaker is Sir Michael Marmot. He is a professor of epidemiology and director of the Institute of Health Equity at University College London. Many of you will, of course, if not all of you, will know Michael's work. He has been one of, if not the, driving force for both research and policy work in relation to inequalities in health. You will remember that he was chair of the WHO Commission on Social Determinants of Health. He then conducted the UK Government Strategic Review of Health Inequities in England post 2010, published in 2010, looking forward, and the 2020 Health Equity in England Michael Marmot Review 10 years on, or the Marmot Review 10 years on. What's important about his work, of course, is that although it has centered social determinants, it is embracing questions of ethnicity as well. And so, short introduction. Michael, I'll hand over to you to give us your talk.
Thank you, James. You can see my slides?
Yes, we can. Yeah.
Well, David Williams has sorted it all out for the US. In a way, the Sewell Report, the CRED report, was saying, yeah, that may be America, but not in Britain. We don't have racism here. So I'm going to think out loud. Does health tell us about social disadvantage and racism? After the CRED report was published, I had a comment piece in The Guardian, and I said, yes, I look at everything through the lens of health. And if there is health disadvantage among ethnic groups, that means there is social disadvantage. COVID, which you've just heard about, maternal mortality, mental health, outcome of pregnancy, all to the disadvantage of ethnic groups. So I said, yes, there is evidence of racial disadvantage. In my Build Back Fairer report, which followed on from the 10 years on, we showed the social gradient in COVID-19 mortality, which was pretty parallel to the social gradient in all-cause mortality. And then versions, you've just seen these figures earlier this afternoon, the big excess in different ethnic groups, which is partly related to geography and to socioeconomic characteristics, but not completely. And that led me to say that, yes, some of the racism, the structural racism, works through socioeconomic characteristics, and some of it does not. There are other things going on. The fact that there's a residual category doesn't by itself mean racism. We need other positive evidence for that happening. I was challenged. I like to be challenged. Jacqui said to me, if you're arguing that the excess mortality from COVID, maternal mortality, adverse mental health outcome of pregnancy, is an evidence of racism, what if other causes of death were favourable? Would you say that's evidence for lack of racism? So what Jacqui did was he looked at more deprived versus less deprived for all these different causes of death, and black versus whites in the US. And you can see pretty well every single cause of death is for the disadvantaged in deprived areas, and in the US, black versus white. But what he showed was that for many of these causes of death, they work to the advantage of different ethnic groups. Maternal disorders, cirrhosis, outcome of pregnancy, to the disadvantage of ethnic groups, but a lot of the rest. And he says, does that mean, by your argument, he said to me, that there's not racism? Unlike a politician, I have to admit when I might be wrong. So it got me thinking. But I said, what about the Hispanic paradox in the United States? If you look, there's white life expectancy, the blue is life expectancy, black, much less than white. Foreign-born Hispanics have longer life expectancy than whites, and US-born lose some of that advantage, but still marginally longer. Now, as David showed you a few moments ago, there's clear social and economic disadvantage to the detriment of Hispanics. If you've listened to what that ghastly man who was president of the United States for 4 years said, on a daily basis, he was illustrating prejudice against people of Hispanic origin, but they had longer life expectancy. So part of my argument was wrong. Regrettably, I'd like to think I'm always right, but I was wrong. I said you can look through the lens of health to see the disadvantage. Well, here's a counter instance where you can't. In the US, as David showed you, and that previous slide showed you, the black-white disadvantage is there for just about every cause of death. Is it social disadvantage, as the Sewell, the Cred report argued, or is it racism? And the answer is yes and yes. It's social disadvantage and it's racism. Public Health England published this well, they didn't publish it, it's a preprint from last week. It's slightly complicated. This is the excess mortality under age 75 by deprivation. So it doesn't give you all the inequality in excess mortality. It gives you the excess within each deprivation group. So in other words, over this period, March 2020 to February 2021, the excess was getting bigger the more deprived the area. That's for the general population. For different ethnic groups, the excess did not get bigger by deprivation. The excess got bigger, but it got bigger pretty well across the deprivation groups. In other words, that's saying it's not just deprivation. Deprivation is important, but there's something else going on in relation to excess mortality during the pandemic related to ethnic group. And that leads to, as David knows well, there's been a big debate in the United States. Should we deal with ethnic disadvantage by general policies of reduction in social inequalities? If people of African origin in the United States earn 60 cents for every dollar that white people earn, if you deal with that economic disadvantage, won't you solve a lot of the racial ethnic differences? Or should you deal with racism? And again, my answer to this is yes and yes. You should do both, no question. So coming back to Britain, in some local authorities, exclusion rates for Black Caribbean children are 5 times higher than their white peers. We know that social disadvantage is related to exclusion, but to argue, as the Cred report did, that it's just social disadvantage, deprivation, seems to me is contradicted by this evidence. If you're a black kid, you're more likely to be excluded from school than a white kid. Strikingly more likely. I followed, as James Nazru said in his introduction, one of the advantages of the CRED report is it brought together a huge amount of evidence. And I've been interested in crime recently because of the overlap between crime and health. And the CRED report said that particularly young, Black, particularly men, but men and women, but particularly men, have higher homicide rates than whites, but most of it is due to deprivation. So I followed the reference. The 50% most affluent areas, Black homicide rates, white homicide rates, white homicide rates, Black, that's Asian, Black homicide rates, white homicide rates, and the 50% least affluent. You can see that homicide goes up in Black as it does in white, and they say most of that Black excess is due to social disadvantage, to deprivation. That's what the data show. What are you talking about? The gap is much bigger in the more deprived areas. The relative difference is smaller, but the absolute difference is much bigger. So that doesn't suggest to me that you can explain away the homicide differences by deprivation. And then, of course, as David has said, there's the psychosocial impact of racism. So it's not just a residual category. There's positive evidence of the effect of racism on the psychosocial pathways. And that leads me back to the 6 recommendations I made in my various reviews, which I think need to apply not just to social and economic inequalities, but to racial inequalities. Give every child the best start in life, education and lifelong learning, fair employment and good work for all, having enough money to lead a healthy life, healthy and sustainable places and communities, and taking a social determinants approach to prevention. And in thinking about the fact that our health was rather poor coming into the pandemic, and we handled the pandemic poorly, coming out of it, I said, we've got to deal with poor governance and political culture, the increasing social and economic inequalities, the reduction in spending on public services, and the fact that we were unhealthy coming into the pandemic. I had in mind social and economic inequalities, but also racial ethnic differences. Put a fair distribution of health and well-being at the heart of all government policy. James.
Thank you very much, Michael, for such a comprehensive talk, and a talk that reminds us that there is a set of processes beyond deprivation that are important. But if we put Michael's talk together with David's, then we also are reminded, of course, that deprivation is also driven by these wider processes as well. So we need to think about deprivation not separately from race and racism and ethnicity, but as part of that process of exclusion. But nevertheless, as Michael has pointed out, we also need to think beyond just deprivation to the wider range of social harms that might be driving ethnic inequalities. And we also have to query the data carefully, again, as Michael has done, and to challenge ourselves where the data aren't quite consistent with our a priori thinking. And taking Michael's recommendation further, of course, we would ask perhaps the CRED team to do the same, to allow the data to challenge their thinking rather than to reshape it to their a priori conclusions. We have had some difficulty with one of our speakers joining, and so we'll just skip over for a minute and hopefully we'll be able to get her back later. But for now, I'd like to introduce who is now our next speaker, Chaand Nagpaul, who is chair of the British Medical Association. He's been a council member of the British Medical Association for well over a decade, and was previously chair of the BMA GP committee. And of course is a fellow of the Royal College of General Practitioners. He's a GP, as you'll have guessed, and a senior partner in his practice in North London, where I'm imagining he's been present for more than 30 years or something around 30 years. But what's crucially important at this point in time is the leadership role that Chaand has played in relation to equality issues throughout the coronavirus pandemic. So we have seen him repeatedly commenting on, advocating for questions around equality, and including in relation to staffing and to patients and race and ethnicity. So over to you, Chaand.
Thank you very much, James, and it's a real pleasure to be at this really important webinar. I'm going to, can you see and hear me first, James? Is it working?
Yes, all working very smoothly.
Fantastic. So I'm going to be focusing on race equality and the medical profession as it relates to the CRED report. And the BMA represents over 160,000 doctors, so we are in a good place to be able to comment on this. And of course, you'll remember that the CRED report described the NHS as a success story with significant overrepresentation of ethnic minorities in high status professional roles. And it went further and talked about the onward march of minorities into positions of power and responsibility in medicine. Now, it's certainly true that ethnic minorities are overrepresented in terms of the medical profession. Nearly 4 in 10 doctors in the NHS come from ethnic minorities, and about 28% of all doctors in the UK have come from abroad. And in fact, last year, more than half of new registrations on the GMC register were doctors from overseas. So it's clear the NHS absolutely does depend on both our ethnic minority and overseas workforce. But however, I'm not sure that the evidence, or I'm pretty clear that the evidence does not support the CRED report's assertion of the NHS being a success story in terms of equality. And what I'm going to describe and show is the disadvantage and hurdles that ethnic minority doctors have actually been facing for decades in our health service, unfortunately. So since its inception, the NHS has always relied on an ethnic minority workforce, but they have actually worked, you know, we're talking about right from 1948 onwards, they have worked over the decades, often against all odds. Those of you who have met many ethnic minorities who've been here for decades will hear from them about having to take jobs in undesirable roles, taking up positions that no one else wanted to take, working in unpopular rotas, often working as perpetual locums, going to different parts of the country, moving around. And in fact, when you look at general practice, many of the ethnic minority doctors that I am in awe of, actually, you know, had to work in end of terraced housing, poor premises. But over the decades, they've worked very hard to build what we now see as modern medical centres. But it has been a tough journey and not one of equity. And in fact, we really should pay our gratitude to the ethnic minorities who have in effect been described as the migrant architects of our health service, and which would not be in existence today and would not be able to carry on functioning if it wasn't for the contribution of our ethnic minority doctors. Now, I'm going to just share some facts and figures around the experiences and treatment of doctors in the NHS. We know as we speak, and this has been going on for a long time, there's differential attainment in medical education in terms of the pass rates of postgraduate examinations. Now, when you look at UK trained ethnic minority doctors and UK trained white doctors, so these are doctors who've been brought up in the UK, there's a significant disparity in the pass rates of examinations, 76% for white doctors, 63% for ethnic minority doctors, and that's even worse if you come from abroad. I mean, it's clear to all of us, the face validity tells you that ethnic minority doctors are not shy of working, they're assiduous, there's absolutely no reason they should not achieve. And in fact, the independent evidence by Catherine Wolfe at UCL has shown that this is not down to a lack of ability, but it is down to issues, structural issues, such as being excluded when they're learning, because learning is a social process, and also often there's an insider-outsider politics. They don't get feedback in the same way, and this impacts on exam pass rates. We know as a fact that there's inequalities in progression. when you look at the most senior level in medical doctors in hospitals, it's the consultant grade. Well, the RCP have shown that you have a far lower chance of being shortlisted for a consultant's position if you're from an ethnic minority. And if you are interviewed, you have less chance than your white colleague of being given that position. There's lack of diversity more widely, with only 10% of trust boards having people from ethnic minorities. There's a manifest ethnicity pay gap, with white consultants paid nearly £5,000 more than those from BAME backgrounds. We know that racist abuse, sadly, by patients has increased in recent years. And when you look at general practice, CQC inspections are more likely to rate practices with ethnic minority doctors as inadequate. And again, when you look at it, there are structural factors here, because those doctors are often working in premises that have lacked investment, not the right infrastructure, lack of staff and so forth, but those are not contextualized in these judgments by CQC. And we also know that there's disproportionate complaints in the workplace. So this is employer bias of disciplining, complaining about ethnic minority doctors more, and the GMC reports twice as many referrals to their fitness to practice panels from doctors of ethnic minorities by their employer. And an independent commission report, the GMC Fair to Refer report, again goes into the structural factors that result in doctors from ethnic minorities being referred more than their white colleagues. And this is down again to being isolated, not feeling able to speak out, and not being supported. When you actually look at the experiences of medical students and doctors, actually from the day a doctor starts training at medical school, there is 4 times the reported rate of bullying and harassment amongst ethnic minority medical students. So much so that the BMA last February, has launched a racial harassment charter for medical schools. And I'm pleased to say that the majority of medical schools have adopted this, but again, it goes into details of structural factors that need to be addressed. When you qualify as a doctor, we continue to see ethnic minority doctors complaining of bullying and harassment twice the rate of their white colleagues, and they're more than twice as likely to say they are afraid of speaking out about patient safety concerns because they feel they will have adverse consequences or even be blamed for that error that they're actually talking about. So this is widespread feedback we've had for quite a few years. When you then look at the COVID pandemic, we're all aware of the tragic fact that nearly 9 in 10 doctors who died of COVID came from an ethnic minority background. But it is of note that the CRED report does not mention this statistic, nor does it actually analyze why this may be the case. And in the following slides, I will suggest some structural factors that may have led to this really distressing statistic. So the BMA did surveys throughout the COVID pandemic, and so we got a good idea of the experiences of doctors. And what our tracker surveys have shown is that doctors from ethnic minority background were twice as likely to feel under pressure, especially during the first wave, which was the dangerous wave, to see patients without adequate PPE. They were about 3 times as likely to be afraid to speak out during the pandemic about their own concerns, about their own protection or safety issues, because they said they were afraid of recrimination, or even worse, afraid of their own career progression being affected. They were less likely to report adequate adjustments when they were risk assessed, and more ethnic minority doctors failed PPE tests, but still felt under pressure to carry on working. So in summary, it is clear that doctors from an ethnic minority background have suffered disadvantage, have had a more negative experience in their lives as doctors. And it's also clear that there are structural factors that have led to this inequity. And just in plain English, that disadvantage and structural factors means there is structural racism in the NHS as it applies to the medical profession. And I think what's really vital is that we recognize it. We recognize it as a fact so that we can actually address those root causes and tackle it. So why does equality matter in the NHS so much and for the staff? Well, firstly, we have a health service that prides itself on equality of treatment for patients. Well, surely we must have the same for its staff. And it's the right and fair thing to do. But more importantly, it also, or as importantly, it also brings out the full potential and capability of our workforce. We have an NHS that is dumbing down the potential of large sectors of its workforce, not allowing them to flourish, be their best, and do their best for patient care. And we know that actually equality in the NHS workplace will be good for patient care, good for patient safety, because doctors will actually be more able to we know that actually the negative experiences actually impact on clinical performance. We know that organizations, hospital trusts and GP providers that embrace equality and diversity actually have more content staff. So it's not just about ethnic minority doctors, but everyone is actually happier. Everyone's more engaged, and the organization is more productive. And it's of course makes economic sense, because hospitals and GP practices that actually are happier, have greater diversity, and have better patient outcomes are going to be more effective as well. So what needs to happen now? What are the solutions? Well, first of all, we do need, in my view, a cultural transformation that embraces diversity and equality in our health service, and really going beyond just correcting a wrong. It's actually about genuinely, from our hearts, valuing equality and diversity as a good in its own right at every level of leadership. It's the good thing to do. And to enshrine that in measures throughout the NHS, we have to have some way of measuring this. The medical curriculum needs to change so that ethnicity, diversity is valued in the education at the first stages of becoming a doctor, so that the system changes, but also education in terms of clinical training. We know, for example, that dermatology training, has pictures of rashes on white skins. That does not actually help doctors train to provide proper, equitable care for all different characteristics. We need senior accountability, and that accountability needs to be very specific, that medical leaders are assessed on their performance on equality. For overseas doctors, IMGs, we have to have comprehensive induction. There is a structural inequality of giving them a half-day induction at the GMC and then expecting them to work in a busy hospital with no previous experience of our health service and the peculiarities and the cultural ways in which we work, and expect them to be able to do a job as well as anyone else who's trained in this country. So that needs to change. We have to create a culture in the NHS that's a no-blame learning culture, and not one that is accusatory, because what happens is those that feel the most vulnerable are the least likely to challenge because they're afraid, and that will go a long way in allowing ethnic minority doctors to feel secure to speak out. The GMC last week, I'm glad to say, has put forward 2 targets with timescales to end differential attainment and also disproportionate referrals for fitness to practice hearings. Now, those are targets, but underpinning those targets, we need the cultural transformation that I've just described. And we need to actually also have systematic monitoring and shared learning of best practice. And there is some good practice going on in the UK in some NHS establishments. We need to disseminate that, but we also need rigorous evaluation of what works and what interventions work, and to ensure effectiveness. And that's where I think the Race and Health Observatory, which I'm proud to be a board member of, has a vital role for the future. So in summary, on conclusion, we believe that whilst many of the recommendations in the CRED report, have value, they are actually ultimately process sorts of recommendations. What we really need is to accept something the CRED report has not accepted openly, is that structural racism exists. Accept it as a fact. And having accepted it, have explicit measures and determination to tackle those factors. And finally, do it by changing the whole culture, the whole ethos of our health service. If you want, I want to finally thank all of you for listening. And if you want to just know more about what I've just been saying, I have written an opinion piece in the BMJ in April. Please just search for it, and you can see what experiences ethnic minority doctors unfortunately have been experiencing in the NHS and what needs to change. Thank you very much.
Thank you so much, Chaand, for that powerful talk, which I think does take on some of the assumptions within the Sewell report quite directly, and particularly in relation to this notion of a success story of ethnic minority doctors within the NHS, and the difficulties that people have experienced within the NHS. I think what's crucially important from my perspective in relation to this is the way that Chaand and his colleagues have carefully traced the evidence on the ways in which racism has played out in the lives of ethnic minority doctors, how that reflects institutional racism, and the consequences of that, not just for the doctors, but also for their patients and for the service more broadly. And I think this is absolutely crucial. I should also say that Chaand has been instrumental in shifting the narrative of the BMA in relation to this, and consequently, at least in my interpretation, in reshaping how the GMC is considering these things as well. So I think it's been a marvelous advocate in this area. Okay, I now want to move on to our next speaker, and I hope our next speaker is ready. Again, I've shifted the order a little bit. So our next speaker will be Patricia Miller, who is Chief Executive of Dorset County Hospital Foundation Trust and has been Chief Executive there for almost 10 years. And she has worked in the NHS for more than 30 years. And important to Patricia, I think, is the improving the lives of patients and of staff in ways that matter to them. She has a very strong focus on equality, diversity, inclusion and health inequalities, and importantly, as a member of the NHS England's Health Inequalities Oversight Group. She is, reflecting some of the statistics that Chaand showed us, she is one of only 8 ethnic minority CEOs in the NHS hospital sector, and so therefore is a crucially important figure for us to hear from. So over to you, Patricia.
Thank you very much. So if we would go on to the first slide, please. Thank you. So when we think about the NHS constitution, we talk quite a lot about why the NHS has not made progress in this space. And for me, the NHS constitution is absolutely clear about the NHS's responsibilities in the space of race equality for staff and also for patients. So when we think about what the Constitution asks us to do, and it talks about valuing every person, whether patient, families, carers or staff, respecting individuals. It talks about the fact that everyone, whether they work in the NHS or whether they receive care in the NHS, has the right not to be unlawfully discriminated against in terms of the provision of NHS services, and that looks at the protected characteristics that fall within the Equality Act. The Constitution also talks about the fact that everyone has the right to be treated with dignity and respect in accordance with their human rights, and the right to be protected from abuse, neglect and care and the treatment that is degrading. So there is, if we were living by the values of the Constitution, there's everything in there that gives us the foundation to build equality within the NHS, whether it's for our NHS people or for the communities that we serve. So the question we ask ourselves is, why is it not happening? Next slide, please. So when we look at the findings of the report and we look at the experiences of our NHS staff, that and staff in the broadest sense, not just doctors, as Chaand was referring to, there's some really clear evidence within NHS data that shows us that we have some very broad systemic and structural issues that we are not dealing with. So our ethnic minority groups are strongly represented in medicine, but fail to break through into leadership roles quite often across NHS organisations. There's overrepresentation in lower bands, underrepresentation in leadership bands of band 8A and above. And again, overrepresentation in some of those most at risk groups, increasing their exposure to infection, as we've seen through COVID, and overexposure to bullying, harassment and discrimination that's experienced on a regular basis. White applicants are 1.61 times more likely to be appointed from shortlisting compared to ethnic minority applicants, and we've not seen any improvement in that figure since 2017 when it was 1.6. In all regions, there is a lower proportion of ethnic minority people on boards compared to the proportion of ethnic minority staff. And if we recall what is asked for in terms of the NHS operating framework around health inequalities and the equality agenda, boards are asked to make sure that they are representative either of the population they serve or the staff group that they're there to lead, whichever is the highest. And we can see that progress is not being made in that space. Next slide, please. When we start to think about discrimination within the health service at a deeper level, we have 82.7% of trusts, with a higher proportion of ethnic minority staff compared to white staff experiencing bullying and harassment or abuse. And when we look at the 5-year trend that sits underneath the workforce race equality standard, that has actually got significantly worse, I think, particularly in relation to Brexit and the context we find ourselves in, but it's got considerably worse over a period of time. So whatever action we're taking, we're not having the positive impact on our communities from ethnic minorities that we want to see. Ethnic minority staff in nursing roles and in medical and dental roles reported that they suffered less levels of harassment and bullying or abuse from staff, but were still experiencing that level of harassment from patients. 16.7% of ethnic minority staff personally experienced bullying, discrimination at work from their manager or their team leader or other colleagues, compared to 6.2% of white staff. And BME staff were 1.16 times more likely to enter the formal disciplinary process compared to their white colleagues. So whichever way we look at those statistics, what we see is that staff from ethnic minority backgrounds have a significantly worse experience of working in the NHS than their white counterparts. Next slide, please. So we look at COVID in particular, and picking up on some of the points that were made earlier by colleagues. Ethnic minority groups experiencing much higher rates of mortality from COVID than their white counterparts. And when we look at the experiences of staff and what the staff survey tells us about the experiences of ethnic minority colleagues who are working through COVID, we see some quite stark differences between their experiences and those of their white colleagues. Ethnic minority staff were more likely to have worked in COVID-19 specific areas, were more likely to have been in frontline patient-facing roles, which put them at greater risk. What we also see is that they were more likely to have been redeployed due to COVID. And in some cases, that means redeployed to a frontline role, not redeployed away from one. White staff were more likely to be able to work remotely due to COVID. So we see that 29% of ethnic minority staff were able to work remotely compared to 37.7% of their white counterparts. And what sits underneath that is the fact that a much higher proportion of ethnic minority staff were employed in frontline roles where working remotely was not an option for them. Next slide, please. When we think about health inequalities, I think I would just add to Michael's points earlier on about the fact that the report did not look at the causes of the causes, and what we know from the research done by Michael and Professor Williams, that the root causes are incredibly important. This is not just about what staff have experienced in terms of health, but it's also about what drives those experiences in terms of the wider determinants and what leads to those. I think that when we think about some of the context within which the NHS operates, it doesn't operate in a vacuum. Our staff don't exist in a bubble. They come from the communities that we serve. And if we accept the point that Chaand made earlier, that structural and institutional racism is an issue within our society, then we also have to accept as a consequence that those issues will be reflected within the NHS that we all love. From that perspective, it's not surprising that we're seeing the institutional and structural issues that we are. And we've got a really big task, I think, going ahead when we think about the new ICS structure and what the legislation requires of us, and requires of us to reimagine and rethink the way that health services need to be provided in the future. And 2 of the 4 strategic objectives set within that are incredibly important to this agenda. 1, reducing health inequalities, and 2, the NHS being seen as a key partner to social and economic development post-COVID. And if we're going to achieve those 2 objectives and really make the fundamental shift that we need to do in the levelling up agenda in our society, then to me, in my mind, equality, diversity and inclusion and achieving equality within the NHS for our NHS people is intrinsically linked to those 2 agendas. They can't be delivered in isolation. And what I observe a lot at the moment is what the NHS is focusing on is the reduction in health inequalities, because it sees that as an easier agenda to deliver than leading to equality within the institution. And I also think that the approach that we take to do that needs to focus not just on the targets and the hard measures. It needs to focus on some of the things that Chaand talked about earlier on, which are cultural shifts and the softer measures, and that there are no quick wins in that. I'm afraid that takes time. Thank you.
Thank you very much, Patricia, for again another powerful talk, and one that reminds us of the broader place of an institution within our society. So not just in terms of the delivery of healthcare, addressing health inequalities and so on, but also in terms of caring for and nurturing staff and the implications of that for broader society. I think the highlighting the role of the NHS in terms of post-COVID recovery and not just in terms of health, I think is very, very important. And I think I and others consider the NHS to potentially be an institution that can lead others in terms of addressing the inequalities agenda in terms of race and ethnicity, setting examples, following the recommendations that people like Chaand are offering in order to redress the way institutions operate, both in terms of its employers and in terms of their wider presence within our society, and leading the way. I'm going to turn now to our final speaker, and apologies, Jacqui, for the technical problems you've had. Our next speaker is Jacqui Dyer, who is Director of Black Thrive Global and President of the Mental Health Foundation, and will be bringing a focus on mental health for us, I hope, which is a crucially important issue at the moment. She's an independent health and social care consultant. She has a background in adult mental health commissioning as well as in community and family social work. She is passionate about prevention and understanding the factors that lead to poor mental health. And in early 2019, Jacqui was appointed as the Mental Health Equalities Champion for England, and she is currently the Mental Health Equalities Advisor for NHS England. So I'll hand over to you now, Jacqui. Jacqui, you seem to be on mute. I don't know whether we need to technically fix that or whether you can. Sorry, everybody. Again, someone who's definitely worth waiting to hear from, if we can. Right, so it seems that Jacqui is finding it difficult to unmute. We will perhaps bring her back in if we can, but in the meantime, let's go on to a discussion, which Yvonne Coghill will be sharing. Over to you, Yvonne, for the discussion. And as I say, if we can get Jacqui back, I think it would definitely be worth hearing from her if we can get her back.
Absolutely. Thank you so much, James, and to all the speakers. That was absolutely amazing. I was supposed to be writing down questions as they came, but actually I spent most of my time listening to what people were saying because it was so powerful, and every single speaker brought something fresh, something new, something different that I had not heard before. So that was great, and the audience have been asking lots and lots of questions. So let me just kick off, and what I'll do is I will ask you individually what your thoughts and views are on something. So if we can keep the answers as succinct as we can, then I can get as many questions as I possibly can. So there were lots of questions for you, Vahe, with regards to the data. And one of them was, did the ONS look at the breakdown based on religion as well as ethnicity when they were doing their work?
Yes, so we have published, well, recently actually on the 13th of May, an update of the differences in COVID-19 mortality by religious group. And we find that most groups are higher risk than the Christian group, especially Muslim in the second wave, which is corresponds to what we find in terms of ethnicity. They are both very intertwined and different dimensions, I guess, of identity, and it's difficult to look at them at the same time because of the overlap. So we haven't done that, but we've definitely looked at religion separately. That's all great. On the ONS website.
Thank you. And again for you, Vahe, there was something about from obviously somebody from a Filipino background asking about the disaggregation of Filipinos, particularly with regards to the numbers of Filipino people that died. And what they've said is that basically that data isn't disaggregated, it's lumped all together in other. Is something that we can do something about?
So the answer, I mean, it is difficult because so the way we decided, we based our ethnicity definition is probably based on the ethnicity from the census that we have, which is 18 category, and Filipinos wouldn't be one of them. Yeah. The only way this could be done would be to look at country of birth. Okay. I guess looking at migrants. So this is something we could probably do. The only worry is the number of cases needs to be large enough for statistical analysis. It's not always possible, but yeah, it's something I'll note down on looking at.
Thank you.
Thank you.
That's great. Thanks very much for that, Vahe. I'm going to go to Michael now because I know that Michael has to leave pretty sharpish. So people were wanting to know why should white people change their behaviour if the system is stacked for them and actually they're benefiting from it? Go on mute, Michael.
The first part of what I said was of no interest at all, so I muted it.
Not true.
It's a challenging question. It depends how you view living in a society. If living in a society is only about your own self-interest and not some commitment to the wider community, then be selfish. Focus on you and your family and forget everybody else. Forget the poor, forget the disadvantaged, forget the disabled, forget people with mental illness, and forget people of different ethnicity. You know, what's it to you? But quite apart from the issue of living in a society, what you end up with is a worse society. So will actually redound back upon you. It's not only the right thing to do, but it's in your own self-interest to live in a more caring society. And we've seen what happened in the last 4 years in the United States, where the president appealed to white interests, to white supremacy, to disadvantaged whites, and said to them essentially, you know what, you may be poor whites, but you're at least better than people with dark skin, so vote for me and you can feel better. And it was a disaster, an absolute disaster. So you can see what it means for a society to appeal to those narrow sectoral interests.
That's brilliant, thank you. And I think following on from that, somebody wanted to know, do we have any evidence about how to stop these phenomena or these things happening to our children so that our children grow up being less, I suppose, infused with some of the things that we're infused with? Is there anything that we can do? And one of your recommendations I saw was about getting to, you know, children early and doing something for them. Is there something that we can do, or the society needs to do, specifically around helping our children to understand the society that we're living in and to make it better?
Well, I hesitate to use a personal example, but one of my sons is married to an Indian woman, and they live a multicultural life, that they don't distinguish between other children on the basis of the color of their skin. They lead a multicultural life, and children are children. Not white children, brown children, mixed children, black children, some other children. They're children. And I think that needs to be our starting point. Yes, indeed, we start. And I think everyone probably on this webinar will know that young children who've experienced multi-ethnic environments are far more open-minded than their parents. It starts early in life. We build in racist and discriminatory behavior. It comes later, but expose children to a caring, egalitarian environment, and they'll grow up in that way.
Well, that's absolutely right. And I think that, you know, there's a song, you know, children are our future, and I think that that is absolutely the case. I think we have to work with our children. I've got a question for you, Pat. Somebody wants to know what you're doing specifically in your organisation to combat racism.
Oh God, I could talk about that forever.
2 minutes, please.
So we are in the middle of a quite wide-ranging programme on equality, diversity and inclusion, and we've broken it down into 3 different levels: leadership and culture, policy and application, and then measurement and accountability. So the board have been on a year of development around race equality, not one session, but a year. That then led to the development of a ED&I strategy. And where we are at present is that our 4 networks, which are set around the principal protected characteristics, are engaged in a piece of work with the executive and our HR team to rewrite our key HR and employment policies through an inclusive lens. We are also just starting this month an inclusive leadership programme, which is it runs over 6 months. It's 6 modules. It is mandatory for everybody of Agenda for Change Band 7 or above who has a line management responsibility, including all of our consultants. And you can imagine we've had a little bit of pushback from some individuals who don't really understand why they need to be on that programme. For everybody of Band 6 and below, they're going through something that is slightly different, which is a programme called Dignity and Respect at Work. And what does that mean in terms of their leadership? So we've got a whole raft of work going on. Where I think we are in terms of measuring the success of that is we're in the very early days. So if we look at our staff survey results for this last 12 months, what we see in those results is a higher proportion than previously of staff from ethnic minorities claiming that they're raising the fact that they've been bullied or harassed at work. I think we were expecting to be in that space because we've spent a year encouraging them to use their voice and be engaged in a programme of change. But what we also see at the other end of the survey is a significant increase in the number of ethnic minority staff who would recommend this as a place to work, and that's because they're starting to see cultural change.
Brilliant. That's brilliant. Thanks, Patricia. James, I'm going to go back to you because I think we've got Jacqui now. I think.
Yes, I think so. I hope so that we have Jacqui, because I think her contribution is going to be great, and an important shift in focus. Let me just again briefly introduce Jacqui. Not that you'll have forgotten who she is, but you may have forgotten some of the detail, and it sets the context for her contribution. So Jacqui Dyer is Director of Black Thrive Global and President of the Mental Health Foundation. She's an independent health and social care consultant with a background in adult mental health commissioning, as well as community and family social work. She focuses on prevention and understanding the factors that lead to poor mental health. And in early 2019, she was appointed as the Mental Health Equalities Champion for England. And she's currently the Mental Health Equalities Advisor for NHS England. Jacqui, I'm so sorry about the technical issues. Do go ahead now.
Hello, good afternoon.
Hello, we can hear you,
Hi,
Jacqui.
Jacqui.
Oh,
Yeah,
wow, that's something. So
that's great.
perseverance reached some reward. Very delighted to be here and to have listened to the wealth of experience and expertise that's already been shared. And perhaps it's not very helpful to draw through all the evidence. From my perspective, the ethnic disparities in the UK mental health system are well documented. Racialized identities are disproportionately associated with a cluster of factors which are themselves precursors of poor mental health and which are associated with aversive routes of entry into mental health services, poorer pathways and poorer outcomes from treatment offered all the way through. The recent Independent Mental Health Act review has supporting documents that illustrate extensive evidence around these experiences. But much of the current evidence about the relationship between racism at individual, societal and institutional levels and health emanates from the USA. So research is urgently needed to strengthen the evidence base and develop responses to address racism and implicit bias in mental health care. Whilst the area is well documented, we continue to do nothing about changing that trajectory. And take my word, it is really bad for Black people. The issue is, what are we going to do to transform the experience and the outcomes? This is where the real struggles lie. And from a lived experience perspective, this is really where I am particularly keenly interested. Even though the inequities are well documented, the understanding of the challenges are still incomplete. Some of these challenges actually due to bias in research, lack of investment in Black-led research, and the reality that studies generally struggle to recruit people from underrepresented groups. The focus on BAME communities previously has also been unhelpful, as the diversity of experience amongst different communities is palpable. The often unsaid dimension is that people who fund research don't trust Black people to lead research. As a Black woman, this is a significant issue. Another consequence of this is that funders determine what we should know. Our whole way of knowing is determined by the decisions of funders, the funders of research. This is partly why the research picture, is incomplete. We are quite preoccupied in documenting the inequalities. For example, the Mental Health Act Commission, now located in the CQC, has described year after year, decade after decade, the overrepresentation of Black communities being detained under the Mental Health Act. We document the psychosis, which means we don't look at anxiety, depression, eating disorders, and the impact of racism interwoven in these experiences of mental health challenges. Predominantly, interventions are not culturally relevant, nor are they delivered by people who look like us. Even if you look at the interventions, when people try to explain why inequalities exist, it's easy to stop exploring beyond poverty, or it may extend to the social determinants of health, but fail to understand those in the context of systemic oppression. That's the subtext that underpins all trauma and mental health experiences for Black people. Our treatment in statutory systems and the violence we are exposed to in those systems is generally not accounted for. In addition, there are not enough Black people in leadership positions, and overwhelmingly, the people who sit on these decision-making arenas or boards are white. My brother died 6 days after George Floyd, and in the midst of the COVID pandemic. He is my second brother that's died in the space of 6 years after decades in the care of mental health services. Barry died aged 53. His anniversary is in 6 days' time. And Carlton, aged 41. His anniversary has just gone May the 5th. I am traumatized by this experience. I worry daily that my only sister, who also has a diagnosis of severe mental illness, will also die young. I am here today to be able to speak only because I have the support of friends, therapy, acupuncture, and medication to help me to face another day to deal with the reality of what that indicates about the mental health care system that we all love and support, but want it to do fundamentally so much better than what it's done. I am forever recalling incidents of where my racialized experiences have taken place in relation to my loved ones and their needs. A CPA where the consultant dismissed my brother's culture because he didn't know it or understand it. So a referral to a religious minister would suffice for that one, not taking into consideration that my brother's 24/7 terror was that he was going to burn in everlasting fire. A thought which emerged, methinks, from his understanding of his faith and the contradictions it held with his substance misuse issue. But no referral, no experience of accessing nice recommended therapies took place. A couple of weeks before he died, his CPN visited my mum after she again raised concerns and begged for help to get my brother into rehab and away from the vultures of dealers who terrorized him daily, said under his breath, after he had said there's no money for rehab, that there's worse off than Barry. My mum heard him, but she never challenged him. She could only disclose the horror of this experience to me. Maybe it's a mercy my brother died when he did, because family alone cannot safeguard a person as vulnerable as he was. It takes a set of public services wrapped around him to deal with his pain. But these services need to be anti-racist. This did not happen for much of his life, even though I, as his advocate, tried so hard to support him. But I'm his sister, and all I want to do is to love him, which I did, no matter what. But we as a family were neglected from support fit for the purpose of dealing with our needs. It should be no surprise to you by now that I am speaking from the perspective of my racialized lived experience. I am driven as a consequence of my experiences to improve things for others, of whom there are many that go through similar challenges, where support offered is often determined by the color of their skin. I am determined in my lifetime that as equal citizens, all people will be treated with the care, compassion, and attention they need, especially when they are at their most vulnerable. I am an activist on these issues. I'm the deputy leader of Lambeth Council, the director of Black Thrive Global, which emerged out of the Black Thrive partnership I founded in Lambeth to attend to the needs of the neglected Black communities of that borough. I am NHS England's Mental Health Equalities Advisor, leading the Advancing Mental Health Task Force and its strategy. Advancing Mental Health Equalities and the Patient Care and the Patient and Care Race Equality Framework, otherwise known as the PCRES, a work which the Race Health Observatory will be supporting as we aim to improve mental health outcomes for racialized communities and the removal of the vulgarity systemic racism is relentlessly pressing upon us. And the removal of that racism is key to achieving the ambition of mental health, racial mental health equalities. Your organisation may soon become responsive to the Patient and Carer Race Equality Framework, otherwise known as the PCREF, that's its acronym, a recommendation from the Mental Health Act Review, which will be rolled out across the country in 2022. I have battled hard for this framework. As for me, the voice of service users, carers and the communities we serve being able to inform service improvements is the only way forward that has integrity, especially when it comes to dealing with racism. The PCREF is an accountability framework which facilitates robust anti-racism activity. It has 3 parts: statutory and regulatory obligations, organisational competencies, and most importantly, a PCREF feedback mechanism where the voices of those experiencing services will be heard more closely in real time to help the equalities improvement. We are co-producing this framework with service users, my colleagues in NHS England, and 4 pilot sites across the country to ensure that we can make it the best it can be and that ownership by all is achieved in its delivery. I am hopeful, but that hope has been forged in the fires of lifelong adversity, and out of it must come a different and better set of experiences and services for people of African and Caribbean descent, as well as other racially minoritized groups. This is a pivotal moment for all of those involved in the provision of mental health and social care services. And so, in relation to the CRED report, I will not be distracted by its content. Rather, I will stay focused on what the needs of our diverse population need us to be equipped and sure-footed in dealing with the realities of structural racism and systemic inequalities. Thank you.
Thank you so much, Jacqui. As I anticipated, this has been an absolutely crucial and important contribution that traces how racism shapes people's lives and their encounters with institutions, lessons learned from the mental health experience, but also the persistence, enduring nature of that over decades. But importantly, as many other speakers have done, looking forward to solutions and the ways in which we can make things better. Yvonne, I'll hand back over to you for questions, if that's okay.
We do. And before I do that, can I just say from all of us to Jacqui, how much we are really, really sorry about the loss of your brothers and what you have been going through over the last year. You know, Jacqui, how much I adore you and love you. And I just think that, you know, anything that we can do to support you and help you, we're all here for you. And on that note, I go to the next question, and I'm going to ask Dr. David Williams this question because it is a tricky one. Sorry, David, but I thought I'd share this one with you. Do we live in a post-racist society, and should we, in Britain, see ourselves as an exemplar country for other people to follow in terms of race equality? Good question.
That is a great question. I am not totally an expert on British society on the one hand. On the other hand, my wife has lived in England and worked in England, and I have relatives who have lived and worked in England, including a relative who's now deceased, who told me stories about when she first came to England many decades ago. She would see signs as she looked for a flat to rent. She would see signs that said no blacks, no Irish, and no dogs. So I do know from the experiences of relatives I have spoken to of the challenges they face. I think this webinar has adequately answered the question in terms of every talk has illustrated ways in which racism still has its tentacles in Great Britain. And that there is a lot that needs to be done. I just want to say one quick note on a point of the question you asked, Michael Marmot, of the cost of whiteness. Why should white people be concerned? I wrote a paper with one of my students just a couple years ago about the impact of whiteness on the health of whites. There are advantages, but there are disadvantages. I'll give you one quick example from US data. If we look at suicide data, the highest rate of suicide in the United States is among older white males. 70% of all suicides in America annually is among older white males. And we have to step back and ask the question, what does it mean to be white? And then to get to an older age, generally over 70, where all that society promised you of your superiority as you deal with frailty, you're not experiencing. And that leads to this markedly elevated risk of suicide in that specific group. There are other examples I could give you, but that's just one example of thinking of these beliefs that are not based in reality actually have cost.
Thank you. No, that was a really, really good answer to that question, which I thought was quite a tricky one. I'm going to go to I think I'm going to go to Chaand now, actually, and ask you, why do you believe that the CRED report, this is another tricky one, Chaand, I'm sorry, but I know you can answer this. Why do you believe that the CRED report didn't contain much of the data and information that we heard here today? You're on mute, Chaand. You're on mute.
Yeah, so I can't obviously comment on why the authors didn't collectively look at some of these issues, but what I think is important is to look at the experience of the workforce. It itself acknowledged that the experience of ethnic minority healthcare workers has been poor in the NHS, but it didn't then go into explaining why and the reasons why. And I want to say that, in fact, much of the data in the CRED report does support much of what's been said today. It's been the interpretation that's been the problem. But I want to just also come back to the issue about, why would someone from a white background in the health service not want to continue having advantage? And I think that, remember, when we're doctors, nurses and others, we're in a system where we must believe, and we do believe, in fairness and equality of the patients that we treat. And it just seems to me absolutely bizarre that anyone would want to suddenly shift from this commitment to equality for the patients we treat and say that it's okay to be unequal with your own colleagues. So I don't believe that is really the makeup of people, or I hope not. And I think the other is the positive, enriching element of diversity and inclusion. That in fact, white colleagues, white healthcare workers, doctors, nurses, actually, we know are much happier. They appreciate the enriched experience of diversity, what people bring. To actually think of someone from overseas coming here and bringing a wealth of experience that you and I will never have experienced being trained in the UK. We need to start to look at this very positively, and I believe by shifting the dial into one of positivity and the benefit, I think NHS institutions can change. But about coming back to the CRED report, I think this is a missing part of the report. It did not look at the experience of healthcare workers. I think this is vitally important for the reasons I explained. I think this is about patient care. It has an impact on patient care, has an impact on the way our healthcare is going to be productive, and it brings out the best of its workforce. But I think that's something that we in the Race Observatory should be now perhaps focusing on, and in fact helping the disparity report to almost have a Mark II, a stage 2. And so many of the contributors today have really provided complementary information, so we don't get into a battle, but really provide the full picture rather than a partial picture.
That's absolutely brilliant and well answered, as I knew it would be. I'm going to hand back to James now. We have many more questions, but what I'm going to suggest is that we take them and put them on our newly, most recently produced website. So we'll put the answers to these questions on the website, the ones that I haven't answered, and I'm going to hand back to you now, James. Over to you.
Thank you very much, Yvonne, and apologies, I appear to be taking away the opportunity for another question or two, which I think would be very useful to have a look at the Race and Health Observatory website in terms of how those, in terms of those questions and thinking about those questions. I don't have much to say, actually. I want to say thank you so much to the contributors, including the two who have had to leave early, Michael and Jacqui, I think, has gone away. Thank you so much for the deep insights from a range of perspectives on the way in which racism is shaping the health experience and the health of ethnic minority people and of people who are working within the NHS, identifying how important it is to address this, but crucially important, thinking through some of the solutions that we need to be implementing. And so what I guess what I would say to the audience and to fellow presenters is, think not just on the evidence of inequality, but also the evidence that we've been provided around solutions. That's where we need to place our effort now. And I think, as one speaker said, I think as Jacqui said, not allow the CRED report to distract us from that crucially important work. And saying that, I'd just like to thank the Race and Health Observatory for hosting this. So Race and Health Observatory is relatively newly established, but is been a crucial moment in the NHS work around ethnic and race inequality. This is, and I liked Chaand's response to the question about why the CRED report didn't contain all of this. This is an evidence-based activity. So bringing together all of the evidence, having the experts examine that evidence to bring in policy and practice in order to develop solutions. And I think this is what this talk, this session was about. It's about evidence, it's about policy, it's about practice and finding solutions and developing those solutions. And the Race and Health Observatory, I encourage all of the audience to remain engaged with the Race and Health Observatory. This is where the work is happening. Thank you all very much. And again, thank you so much to the speakers for contributing. And goodbye to everybody.